COVID-19 has rocked how hospital procedures are handled, with cleanliness and stopping the spread of the virus a top priority. This includes how surgeries were or weren't carried out. We'll dive in deeper into this topic coming up on Being Well.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.
They're the ones who raise the bar. The ones dedicated to providing care in the most demanding of circumstances. The ones that understand the healing benefits of kindness and compassion. They're the people of Sarah Bush Lincoln, and they set the bar high. Sarah Bush Lincoln, trusted, compassionate care right here close to home.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.
Thank you so much for joining us today for Being Well. I'm your host, Lacey Spence, and today we are talking about surgery in the COVID-19 climate. Obviously, that's really rocked our world this year. And joining us today for our guest, we have Dr. Iyoob Ilyas with HSHS Medical Group, also working at St. Anthony's Hospital in Effingham. You are a general surgeon and colorectal surgeon?
Correct.
Perfect. We got all the way through that. So first off, how has COVID-19 impacted the surgical climate?
Thank you for having me. Yes, these are interesting times. And like with everything in life, it's so interconnected, and more so in a hospital setup, particularly when you're dealing with a pandemic of COVID-19's proportion. To understand the effect of COVID-19 on patients or surgical patients, we need to understand how we got here, the brief history of COVID-19 since December of 2019. We knew of COVID virus the later part of December of 2019. That's how it got the 19 tag on it. Mm-hmm. And we had our first case in the United States on January 20th. And after that, we started taking COVID-19 more seriously and taking concrete measures towards COVID-19 during the later part of March. So we had a lead time of about 2 to 3 months, and we did not very actively react to COVID-19 situation. That led us to 3 difficult issues to deal with when we were inundated with the cases. We all know the first thing is testing. We all have heard about it. Mm-hmm. So for a virus, infectious virus, which is prevalent in a community, in a city, in a country, we need a test which is accurate and cheap and a quick turnover time and widely available. And all these parameters have to be met. And so during the month of March, April, and May, our tests have gotten more refined. Now we have better tests which are more accurate, but we still have, in most places, have a turnover time of 24 to 48 hours. Number 2 issue is the testing is also important because to contain the virus, because the term what we call as contact tracing. I would like to, we have not done a robust contact tracing as yet, at least.
Mm-hmm. And just for our viewers at home, we are taping this in June, so who knows what the future holds.
Absolutely.
Just to throw that out, sorry to interrupt.
Yeah, it's very important, because if you look at it, South Korea and the United States on Jan 20th officially had their first cases. Mm-hmm. South Korea's population is about 1/6 of us. And we all started doing the social distancing and wearing a mask and whatever we did over the last 3 months. Similarly, South Korea also did, but they were more robust with their approach, most of it contact tracing. So if you look back now, 3 months later, South Korea has got 281 deaths for a 50 million population, 1/6 of our country's population. And they've got about 12,000 cases. We've got 2.5 million cases. We've lost about 121,000 Americans. And we account for 4% of the world's population, but we account for 25% of the world's cases and 25% of deaths across the world. So the testing and contact tracing became important, number one. Number two, the famous term PPE, professional protection equipment. What does it mean? It means the masks, surgical masks or N95 masks, sterile gloves, sterile gowns, and all those amenities which are needed in a hospital to take care of patients in the ICU, to do a procedure or do surgeries. In March and April, when we were inundated with cases, and when we realized the gravity of the situation, the dynamics with which we work in a hospital completely changed. The approach with which we were dealing with patients changed. So we decided to do only essential consultations with the patients, or urgent or emergent consultation with the patients. And we decided to postpone non-essential or urgent or non-emergent procedures and surgeries. Essentially for two reasons. Main reason is to preserve PPE, because we did not know whether we are going to be run over by this virus, like it was happening in New York and other places like Washington. And so across the country, we decided to stop all of the procedures, including elective surgeries, and not just the office visits as well. And the second point in that aspect is to ensure the safety of the patient, because we did not know how safe it is to operate on a patient who potentially has a virus for two reasons. One, we did not have the testing available widely to ensure that a person who's going to be operated with or without the virus definitely does not have the virus. Number two, two studies right now, till now we have only 2 studies which shows that patient were asymptomatic carriers, like you and me, no symptoms, but God forbid if we carry the virus, if we need a procedure, we go through the surgical procedure, what happens to us? And 2 of the studies, the first one is from Wuhan, the second one is an American study. Both of them show an alarming mortality rate, loss of life, after normal procedure like a gallbladder or cesarean section or any major procedure. They looked at all of those, of 20%. And it's very high mortality rate. 1 in 5 is going to die if they were asymptomatic, just because they had COVID, which we did not realize they had it. So that played, we wanted to ensure the safety of the patient. So we said, hold back, let's reevaluate the situation. To complete the list of issues I was talking about, the third issue was about the ventilator. How does ventilator impact it? Because we know what happened in New York. When we were worried we were going to be run over by this virus, all of the ICUs were full. The backup, apart from the Federal Reserve and all of those reserve ventilators we had in other places, are the ventilators available in the operating room. So it happened in Italy when their ICUs got full, those patients were admitted to the operating room so that they can be ventilated in the ventilator, which is usually connected to the patient when they are asleep during surgery. So for that reason as well, we stopped elective cases in case we need to make use of those ventilators in case we get into a dire situation. I think out of the 3, we did better with the ventilators, because it would be tragedy to ration a ventilator. You know what I mean? Is like it happened in Italy. We were pretty close to that in New York for most part, but we survived that dreadful scenario. So that's how our approach towards surgery and surgical patient changed because of COVID-19.
And that's just the patient side. I mean, as a physician, did you ever worry about your safety or not having enough PPE?
A PPE, for various reasons, and has been no physician, no healthcare provider, no hospital system has till date have been in a comfortable situation, let's put it that way. It has improved since, because traditionally we've been depending more on overseas resources, or the channels which gives us the PPEs dried up because they were inundated with the cases. Everybody were holding back on their reserves.
Right.
But over the last 3 months, things have improved, but not to the extent we need. We still reuse the masks, and we will not use an unverified and legit mask within the operating room. And during those situations, masks were being produced in small industries at home, and people are 3D printing masks. We do not know the quality of those masks. They were not verified yet, but we were in such a dire straits that we had to use them. Mm-hmm. So PPE has been a major issue, and we did lose a lot of healthcare providers, nurses, doctors, and other healthcare providers, and even other hospital personnel to COVID-19 because of PPE shortage. And this is across the world, and you see that a lot in third world countries. And I come from India originally, and I do know right now they are going through a very difficult phase. And there's a lot of healthcare providers are being infected because of real difficulties with PPE. So surgery, when you deal with a surgical procedure, you got to ensure not only the patient safety, the safety of the operating room personnel. Mm-hmm. And so the way we do surgery has also changed.
I bet. And so as you're talking about having to postpone these elective surgeries, what kind of implications can that have on the patients who have had to wait?
We talk about non-essential surgeries, but to me, all surgery is essential. If it's not essential, you shouldn't do surgery.
Yeah, why are you doing it?
Yeah, I'm not talking about the part I'm not talking about is cosmetic surgery. Sure. You have a different discussion about it, and I don't do them. So all surgeries are essential. Mm-hmm. So the question comes is the timing of the surgery, right? When you say elective surgery, and then urgent surgery, and then emergent surgery. And let me give you a simple example. Let's take a simple issue like hernia. Okay. A symptomatic hernia, if someone sees me in the office, I put them in for surgery in a few weeks, at the max 2 or 3 weeks, we end up doing the operation. Why do we do the operation? To take care of the symptoms, so that prevent complications, so that the bowels don't get obstructed, and we don't have to resect bowel. It doesn't become a larger operation, it doesn't become an emergency operation. Let's take gallbladder. Gallstones, symptomatic gallstones, you got some pain, you can take care of it. Even if there is a delay, it's only the question of pain we're talking about. But gallstones can cause something more, pancreatitis. More so if they have something more serious issues, let's say cancer. If someone has cancer, the first thing they want is get this taken out of me ASAP.
Right.
And that's got significant impact both from cancer-related survival plus psychological aspect as well. So it's got significant impact on the patient, not just from the medical point of view as well as psychological point of view. So it's very difficult to have those discussions with the patients. But we were in March, April, May, when we had to hold back. We didn't know the amount of risk the patients had to take personally, as well as the social risk involved of preserving PPEs. And it was a hard discussion we were having with our patients those 3 months, mm-hmm. to ensure that they understand and they make a very informed decision about delaying surgery.
So what did emergent surgeries look like, where in kind of that split second, somebody comes in and they need surgery now, as far as testing or clearing them for COVID? That has to be very challenging.
And that is why, when I put it in the beginning as in testing, it becomes, like you said, it's very important. Two scenarios. Elective surgery now has changed. I have to explain the elective scenario pathway now to understand its implication in emergency surgeries.
Okay.
So now what we do is to ensure patient safety and the safety of the personnel in the operating room and their post-operative stay, if they had to stay in the hospital, of the nurses in the hospital, from the patient. And to ensure the safety, what we do is we do testing.
Okay.
Most hospitals do the like 3 to 4 days before they do COVID-19 testing. And some hospitals do 2 tests between a 24-48 hour window period. And after that, we ask patients to self-quarantine themselves. Because if they were in the incubation period, wherein the test could be false negative, still the test is not 100% accurate. Initially, we had about 1/3 false negative, meaning they had positive, but the test could not find them to be positive. But now I think those tests have become a little bit more accurate. And so that reduces the number of patients technically who are asymptomatic carriers ending up on the operating room table, taking a 20% mortality risks.
Sure.
Next is we changed a lot in the way we do the surgery, each and every steps of it. We can discuss that again later. And third, also about the post-operative care of the patient is also, we have made a lot of changes to ensure the safety of the patient and the hospital personnel. So in an emergency situation, like I said initially, we need a test which is quick,
Right.
and the turnover time should be or like what we call as point of care test. In the past, a lot of our knowledge about COVID and is related to how we historically responded to other infectious diseases like respiratory illness diseases in the past, like influenza, or other infectious diseases like HIV or hepatitis C. In the past, we used to have a point of care test wherein a person, a lot of places was mandatory. Anyone who gets a surgical procedure gets their hepatitis C status known, HIV status known, so that operating room personnel can take more precautions. You need to take universal precaution for everyone, but a little bit more additional precaution in their cases, particularly handing over sharp instruments so that they don't get an inadvertent needle prick injury.
Right.
So the problem with the point of care test is still not available widely. They are available in some places, they're not accurate enough. So right now in Coles County, where we are, we don't have a point of care test available. And the turnaround time is about 24 to 48 hours, which means now we have that whenever we do an emergent surgery, I explain to the patient that if you are asymptomatic carrier, even without symptoms, you carry a risk of 20% mortality if you were to be positive. So it's hard. It's just not for the patient, for me and my team and rest of the hospital personnel. It's again not the most optimal situation we are under. Still, it is high risk for healthcare workers.
Definitely, and major kudos to anyone in the medical field who's had to deal with this, because even just being a regular person dealing with a global pandemic, I mean, there's challenges I face, but what you all are facing is, I mean, it doesn't even compare.
Yeah, it is. At one point we did not know at the beginning the seriousness of the issue, and then when we realized the seriousness of the issue, we did not realize how serious it is going to be. And like with everything else, we kind of getting used to it. Now we are able to take more. We do know that we realize the risks. The risks got normalized. Let's put it that way. Yeah.
And I also want to mention again, just for our viewers, we are recording this in June. So advances in testing may happen before this airs. I just wanted to throw that out one more time. And so as you're talking about testing patients prior to coming in for a procedure, how does that work if there's other people in their household who maybe didn't get tested? They're still going to work while I'm isolating.
Very valid question. And so there's a lot of deficiencies in this.
Okay.
And yes, like you said, if someone else is at household has and then they get infected in the meantime, that is a risk. We are taking it at this point. An ideal situation would be point of care testing just before the procedure. And or complete quarantine, which is not possible, or admit them and quarantine them at the hospital, which are not feasible in the current climate. So the risk mitigation is definitely not 100%.
So are there some ways that the surgical world has kind of adapted to these changes that we haven't hit yet?
Pre-operative wise, whatever we talked is what is considered as standard now.
Okay.
But from intraoperative point of view, how does the virus spread matters, because the virus spread by droplets. We all know about it. But there's something more which we all have data, but to be honest, we are not really wanting to accept that, embrace that, and make changes in our day-to-day life, because it's going to be very difficult for us. It's the aerosolization. Like as I'm saying, and around me, if I have virus, there is virus around me. And the 6 feet is optimal, but not 100% good enough. And so what happens is, during surgery, if someone were to have an operation, they need to be intubated. You put a tube through the trachea so that they can be connected to the ventilator. So the air from their trachea comes out, exposes the anesthesiologist and rest of the nurses to the virus, if they have the virus. Imagine if it's an emergency operation, if it's an asymptomatic carrier. So they're going to be exposed to the virus. And number two, so we have made N95 mandatory for everybody. And we keep a limited number of personnel in the operating room when someone is getting intubated. And we make some air circulatory changes to the air circulation within the room to ensure that, to reduce the risk. And there are procedures, like when you use a Bovie cautery, and the plume can have viruses. This is again extrapolated from our previous viruses which we know of, like HPV virus. So what we do is, we don't want to expose the operating room personnel when we're using a Bovie cautery to cut tissue. The electricity is used to cut tissue so that they don't bleed, so that those plumes don't, other operating room personnel don't get exposed to. Similarly, I'm a minimally invasive access surgeon. Like I do mostly robotic surgeries, 95, 99% of the time, which means small holes, and we inflate the abdomen with carbon dioxide. So if someone were to have COVID virus, and I use various energy devices within the abdomen, so we burn tissue, cut tissues inside, so those plumes which are created inside the belly can leak through those CO2 exchange. We put ports in, and that can potentially expose others.
Man.
So I have to thank American College of Surgeons, American College of Colorectal Surgeons, and Society of American Gastrointestinal and Endoscopic Surgeons, called SAGES. They've done phenomenal work on this. And they came up with how to make it more safer for operating room personnel, so that even if you end up having a patient who is positive, whom you don't know of, the exposure is limited. So we've made additional filters, and how do we operate has also changed. Similarly, we also ensure that these patients stay for a limited number of days only in the hospital as long as possible, so that their exposure to other patients. So because one of the places of high risk of infection is hospital or healthcare settings. So you don't want to stay in the hospital more than what is absolutely necessary.
Try to get them in and get them out.
ASAP, as early as possible, yeah.
Awesome. Well, that's a lot of great information. Obviously, things are changing pretty rapidly. Again, we are recording this in June, so a lot might have changed by then. But we want to thank you, Dr. Iyoob Ilyas, for being on the show, and we will see you next time for Being Well.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.
They're the ones who raise the bar. The ones dedicated to providing care in the most demanding of circumstances. The ones that understand the healing benefits of kindness and compassion. They're the people of Sarah Bush Lincoln, and they set the bar high. Sarah Bush Lincoln, trusted, compassionate care right here close to home.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.